Welcome to another edition of Inside the Training Room. This week we're going to talk about foot and ankle. I want to welcome Dr. Ellington.
Hey, thank you for having me on. Excited to talk about all these issues.
Okay. First of all, let's start with some basics first. Can you walk us through what the anatomy of the foot is?
Sure. So, as you mentioned, I'm an orthopedic surgeon with the Foot and Ankle Fellowship uh, interest, and I did it's one of those things to me, that in a kind of a prideful way, take strong interest in the anatomy of the foot and the ankle because it's so complex. And I like to joke along with my other partners, that are hip docs or knee docs, that they're just dealing with a couple bones and one joint, but the foot is very, very complex, and it's quite remarkable structure. It's got 28 different bones, which that comprises about 25% of the bones in your entire body. It has 30 joints, and there's over 100 muscles and tendons and ligaments that attach to those different bones and joints in the foot. And all these things work together to provide support, stability, balance, and mobility, and explosion, which is what the athletes are really interested in when they're out there on the court or field playing. And so it works in all these very intricate, small, complicated things work together to create a pedestal for the human body to be able to do, easy standing and walking locomotion to excelling in all types of athletic endeavors.
Yeah, and I think over the years I've probably hurt all 28 of those bones and joints and muscles. So moving up, another favorite part of my anatomy is the ankles. Can you talk about the anatomy of the ankle too?
Yeah, so the foot, is in basic terms that tripod of the heel, the big toe, and the smaller toe, and they all come together to form joints in the midfoot and the hindfoot, and then the joint below the ankle called the subtalar joint, and that joint is responsible for side-to-side motion. And then on top of that is the ankle joint. And the ankle joint is what the shin bone comes down and attaches to the foot. And the ankle is uh, kind of like a square looking joint, and it has the inside part, which we call the medial malleolus, and it has the outside part called the lateral malleolus. And then it has the talus, which is a foot bone that sits under the shin bone. And that complex of bony anatomy creates the ankle joint proper. And it's really important because when people talk about having an ankle fracture or breaking their ankle, in generic terms, they're talking about breaking that inside bone, that medial malleolus, or that outside bone, the lateral malleolus. So that forms the ankle joint. And then around the joint of the ankle are two very important parts that are ligamentous. And one of those is called the syndesmosis. And so that's frequently referred to as when patients or players have an injury, they call it a high ankle sprain. And that's where they sprain the syndesmosis, which is the ligament that connects the shin bone and the fibula together. So there's two bones in the lower leg, the tibia and the fibula, and the syndesmosis connects those two bones together. And if you sprain that, that's called a high ankle sprain. That's a common thing you hear about in sports. You see it on ESPN a lot. And if you tear that, then that's just as bad as an ankle fracture. If you tear the syndesmosis, that's not a sprain. That's a full-on tear. That requires surgery, just like if you broke your ankle, you broke the bones. And then there's the ligaments on the inside and the outside of the ankle that are commonly referred to as, the ankle ligaments that you sprain when you twist your ankle playing sport, or you fall off a curb or twist it on a step. So when you sprain your ankle, those ligaments on the inside and the outside are really important to the stability of the overall ankle anatomy.
Okay. And so a lot of moving parts in there, and they all carry the weight of our bodies. So a lot that can get injured. Talk about some of the common injuries that you see to the foot.
Yeah, so I mean, well said. There's a lot of moving parts, and because of that, unfortunately, there's just a lot of ways you can hurt your foot. And so if there's a bone, if there's a ligament, if there's a joint, if there's a tendon, etc., any of those things can be hurt in the foot. And the common foot injuries are one of the most common ones we see in athletics is a Lisfranc injury. And the Lisfranc is one of those ligaments I talked about that connect the bones together inside the foot. And it's really, really important to the stability of the foot. And it helps provide force from the heel to the forefoot. And so imagine if you're running or jumping or cutting, you're transmitting force from your calf muscle down to your heel, through your midfoot to your toe, so you can push off and have that explosion. When you have a Lisfranc, you have a disruption in the middle of the foot, so you lose the ability to transfer that energy and push off and have that explosion. And that Lisfranc injury is that ligament resulting in instability of the midfoot. And when a patient has that, we fix that with surgery. That's one of those things that, unfortunately, if you have this type of injury, it results in surgery. In fact, I fixed 2 yesterday in collegiate football players, one in an NFL player 2 weeks ago, and then I saw a guy today in clinic, another collegiate football player who tore his Lisfranc. So just in 2 weeks, I've fixed 4 people at different levels of athletic ability due to tearing that ligament. So that's a real common one you see, again, one of those ESPN ticker tapes, around here in Charlotte, famously, Cam Newton had a Lisfranc injury last year. So in addition to that, another common injury that we see in athletic population is when patients have an injury to the bone in front of their ankle called the navicular bone. Most commonly, we see that it's a stress reaction or stress fracture in the athletic population. Now, luckily, a lot of times those things can be treated non-operatively, but if it doesn't heal because that particular bone doesn't have a good blood supply, it can go on to have continued pain and then need surgery. In addition to those, another common thing that we see in the athletic population is something called a Jones fracture. And that's a fracture where you break the base of the 5th metatarsal. And likewise, that bone, kind of like the navicular, has a very poor blood supply. So when an athlete breaks that bone, that pretty much always results in surgery as well, because they don't do too well with non-operative treatment. And again, a Jones fracture is one of those other common fractures you see about on the ESPN ticker tape, because it's a common fracture along with Lisfranc in plaguing collegiate and professional athletes. In addition, turf toe you hear about a lot, and that's where you kind of tear the ligaments under the big toe, and that can cause the big toe not to function properly. And in a normal dude, that might not be a big deal, but if you're a runner or athlete, basketball, football, soccer player, tennis, volleyball, whatever, where you really do a lot of running and cutting, it's an injury to the big toe can be a devastating injury. It's ended many people's career, even at the professional level. So it's a big deal to have a turf toe. And under the big toe, there's 2 bones called the sesamoids. These little bones, they're like the size of peanuts. Even they're small, but they can cause some problems. And we often see those patients having injuries with these particular bones in runners and dancers and cheerleaders, where they do a lot of pressure on their forefoot. And then, like you kind of said, those are the more common ones, but then if there's a bone in the foot, it can be broken. So any of the other fractures can happen. Now, luckily, those other ones oftentimes can be treated non-operatively. In addition, you can dislocate the foot. There's several different common dislocations that occur in the foot. Most commonly is the joint below the ankle called the subtalar joint. You see that can happen. More commonly seems to be in football, baseball, and basketball, and dislocating that joint. And then lastly is stress fractures. And this is a common thing we see in athletes, especially in today's way that they train. And everyone that's trying to make it to the next level really puts a wear and tear in their body, and they can overtrain and overwork. And so it's not uncommon to see guys and girls come in that are 14, 16 years old, just really pushing their bodies to the limits. And in fact, I saw a girl last week. She's 16, high school track runner, and she's trying to be the best on the team, and I commend her for it. But she had a 3rd metatarsal stress fracture, where just too much literally just broke. And so stress fractures can occur in the foot as well.
Yeah. And then onto the ankle, not as many parts there, but I think everybody that's ever walked or run has twisted their ankle or strained their ankle. What kind of injuries do you see there?
The most common we see is what you just mentioned, is the ankle sprain, and that could be something where you just kind of tweak your ankle playing basketball. You come down on some other player's foot, or happens in soccer a lot, where you just kind of sprain the ankle, and it's bad for a few minutes to a few hours, and it's better after that. Most ankle sprains do last anywhere from kind of 2 to 4 weeks, and they rehab on their own. The trainers and the therapists do a great job in getting those patients back on the field pretty quickly. The problem with the sprain is that same ligament, if it doesn't heal properly, and in about 10 to 15% of the time it does not, that ligament loses its strength, and it's really loose, and that causes instability to the ankle, and then we have to go in there and fix that. So like if you tear your ACL, right, that's a ligament in the knee, that we always fix that. Well, if you tear the ligament around the ankle, if it heals on its own, again, about 90% of the time it will, you don't need surgery. But if it tears and doesn't heal, then you do need to repair those ligaments. You can break your ankle, as I kind of mentioned to earlier. You can break the inside, you can break the outside. Oftentimes we fix those. Occasionally you can have an ankle fracture, does not require surgery. And then as any joint, you can dislocate the ankle, and that's pretty uncommon injury, but ankle dislocations do occur. And in any joint also, you can have a cartilage injury. And we see this pretty commonly in athletes, where if you have a really bad ankle sprain, it twists the ankle so bad that not only does it tear the ligament, but as I mentioned, the ankle's kind of like a square. And imagine, it does great when it's going up and down, but it doesn't like to go side to side. So when it goes side to side too much, you can actually tear the cartilage inside the ankle joint, and that can be a problem that can require surgery. And then there's tendons all around the ankle. So there's the Achilles tendon, there's tendons on the outside, there's tendons on the inside, and they can be injured through just kind of micro trauma over time, or you can have a full out rupture and require surgery in those situations.
Okay. So because ankle and foot injuries are fairly common in everyday life, how do we know when it should be evaluated, and how much time should go by before we head in, if we're kind of wondering, well, maybe a day from now it'll get better and I won't be hobbling around as much? What kind of indication should a patient look for that say, I need to go see Dr. Ellington?
Yeah, so your comment about the commonality of it, it's quite interesting. So 45% of all injuries that occur in the athletic population are to, so that takes into consideration hip, knee, wrist, shoulder, everything. So 45% of all injuries are in the foot and ankle. So they're very, very common, as you mentioned, and that's a big part of my practice. And it's an enjoyable part because I love taking care of people who, have an injury, and we can get them through without surgery. And then there's that occasion they do need surgery. So the times you need to come in and be evaluated is if you felt or heard a pop, that something happened, right? So if you felt or heard a pop, either a ligament tore, a tendon ruptured, or a bone broke. And that doesn't mean it needs surgery, but if you felt or heard a pop, then something definitely is not right. So I think if you had that situation, it's probably a good idea to get evaluated, especially if some people can feel a pop and have a problem, and in a day or two, it's feeling a lot better. You could probably hold off on that, but it's always better to be safer than sorry. If you have swelling, it doesn't improve. So if it's been a couple days and the swelling just not getting better, you just don't see a difference in the swelling of the extremity or the color, it's something to get checked out. If you feel like it's unstable, that you can't trust it, or you can't put any weight on it, the inability to put weight on the foot is a telltale sign that there's something pretty bad. And if you have done these things and you felt the pop and you kind of did the rice treatment yourself, and you felt like you're kind of making some progress, and you're trying to get back to being an athlete or just recreationally, and you feel like you can't accelerate or decelerate like normal, those are other signs for you to come on in and be seen.
Okay. And then once somebody comes in to see it, what's the evaluation process look like? What are some of the things that you do, and maybe tests that you run to determine the nature of the injury?
So we always start out first with a thorough history, talk to the patient, what happened, how did it happen, when did any circumstances around it, did anyone witness what happened? Sometimes players will bring in video of a tape of what happened. Those things are really critical to understanding the kind of the mechanism of the injury. After obtaining the history, we do a thorough exam. standing exam, seated exam, palpation, and stress testing of the ankle, leg, and foot to evaluate if there's any instability or torn ligaments or tendons. We take x-rays all the time, and really strongly suggest standing x-rays. So a lot of patients may come in with an x-ray taken in urgent care or the ER, and unfortunately they're inadequate to really assess what's going on. So if you've had those, we'll repeat them, we'll get standing x-rays. And then after that, depending on what's going on at that point in time, after the history exam and x-rays, depending on how long it's been since the injury, if it's been probably 2 to 3 months and you're not making progress, then we'll order an MRI. That MRI is great at looking at cartilage, the tendon, the ligaments, the bone, in much better detail, and give us a better assessment of what's going on, and is there a role for continued rehab, or is there a role to switch gears and move towards surgery?
Yeah, you touched on it just a second ago about the different kind of treatment options. Can you run through those from the range of like the minimal to most radical as far as surgery goes, or as far as treatment goes?
Sure. So, my job as a surgeon is to treat people without surgery. I say that line 30, 40 times a day. And so that's what we're here for. We always want to be conservative. So we start off with giving people some basic rehab to do at home, the RICE treatment, rest, ice, compression, elevation. Our physical therapists who are really talented at helping patients with pain and swelling and getting their strength back and their proprioception and balance back. Sometimes we'll use anti-inflammatories by mouth or creams, and occasionally we'll do an injection of an anti-inflammatory such as a steroid. In addition, we'll do some taping and bracing to help support the ankle or the foot. And then if all these things don't get us where we want, we can use sometimes customized bracing or even custom orthotics to support the foot. And then our last option is if those things don't work, or depending on the overall diagnosis, we'll move to surgery. And so simply, if the joint's dislocated, we'll pop it back in. If the tendon's torn, we'll fix it. Same for the ligament and same for the bones. And the goal is to restore the anatomy, because anatomy is function. And so what we want to do in orthopedic surgery is put the anatomy back together the way it was pre-injury, so the patient then can have restored function to get back out there and do what they enjoy doing.
One thing I've learned about OrthoCarolina in this series is the emphasis on prevention. And there are things athletes can do to help themselves prevent these injuries. What are some of the things that you would recommend for athletes to do to prevent foot and ankle injuries?
So take advantage of your physical therapists and your trainers and your coaches and friends and colleagues, and listen to your parents, and it's important to really focus on strength conditioning. The science of strength conditioning has expanded dramatically over the last 10 to 20 years, and it's incredible what we know about the human body and how it reacts in different situations on the playing field. And so you really want to focus on that and training. Core strength is really important. It's something that people like to ignore and put off last, or they'll skip it and they'll do it the next day, the next day, the next day, and the next thing you know, never doing it. And you really want to work on core strength and balance. Stretching is important, and there's a little bit controversial at times, but I do think stretching before and after can be helpful. If you do have a little sore area or something you can't really truly rely on, then bracing can be helpful, and taping to help prevent further injury to get you through the season. And then it's hard to do, but some of the best people do it, and that's playing control. And there are people out there that have played all through middle school, high school, college, and pro, and never been hurt. And they seem to just know how to, control their body and avoid certain situations. And you want to be intense, you want to be impactful, but at the same time, you do have to have some sense of playing within your bounds. And I think that combination of things can help increase your ability to perform and prevent injury.
All right, that's terrific. I really love the playing and control I wish somebody had told me that many years ago. Probably could have taken a little wear and tear off of my feet and ankles. Dr. Ellington, we really appreciate you joining us.